Before starting the discussion of abnormalities in the respiratory function, I would like to remind some characteristics, both structural and functional, of the respiratory system. This slide illustrates the lung volume and capacities as demonstrated by spirography. The tidal volume, this is the amount of gas inhaled and exhaled with each resting breath. The residual volume, this is the amount of gas remaining in the lungs at the end of the maximal exhalation. The vital capacity, this is the total amount of gas that may be exhaled after a maximal inhalation. This is the vital capacity. The vital capacity and the residual volume together constitute the total lung capacity. This is here the inspiratory reserve volume, the amount of gas exhaled after a normal expiration, and the expiratory, inhaled and exhaled after a normal expiration. So, normal inflation, normal inspiratory volume, and inspiratory reserve volume. Both the inspiratory reserve volume and the expiratory reserve volume constitute the vital capacity. As we can see here inspiration and expiration take about 5 seconds. This picture illustrates the anatomy of the airway, vascular and lymphatic structures of the lung. The bronchi, ending with alveoles, the pulmonary artery, the functional circulation supplying the alveoles and the pulmonary vein, and also the bronchial artery, the nutritive, the second set of circulation, are shown. These are the bronchomotor nerves here and the lymphatics. A specific characteristic of the circulation in the lungs are the anastomoses, the connections between the functional circulation and the nutritive circulation. Functional circulation includes the pulmonary artery, these are the respiratory units, and the pulmonary vein, while the nutritive circulation includes the bronchial artery. Microcirculatory units are emptying into a bronchial vein and later into the azygous vein. However, some respiratory units close to the functional circulation are emptying in the functional circulation. So, a little portion here of venous blood may be present. Let me remind, the pulmonary vein is carrying oxygenated arterialized blood. Anyway, this amount is too small and it can be neglected. However, this anastomosis may be important under pathological conditions. Another characteristic of the respiratory system, this is the defense. The defense in both the passageways and into the parenchyma, into the alveoli. In the passageways, the defense is presented by the mucociliary blanket, mucus produced by the cells, epithelial cells, and the cilia movement, thus exporting every dust or other particles or microbes that are exhaled outside. If dysfunctioning, for example, in smokers due to the metaplasia and loss of cilia, bacteria may penetrate into the alveoli. Anyway, in the alveoli, these are the bacteria, we have additional defenses, macrophages, antibodies, and other components of the immune system such as complement. So, in the alveoli space, the bacteria may be attacked and destroyed. Every defect into the immune system will cause significant complications. For example, in AIDS patients with compromised immune system, the pneumonias are a frequent complication. This picture illustrates the subdivisions of the passageways, both the conducting airways and the respiratory airways. Trachea, bronchi possessing cartilage components, and the bronchioles devoid of cartilage components. Both subgroups of bronchioles non-respiratory and respiratory possessing alveolar distensions. These are here the alveolar ducts and the alveoli. They are numbered, so this number will be present in the next presentation to indicate the passageway involved. This is here the participation of the passageways in the conductance of the airway, airflow, and the respiratory zone. This is here the total cross-section of the airways. As you can see, the higher section is in the respiratory zone, the terminal bronchioles. In contrast, the resistance is greater in big airways and decreases being lowest in the terminal bronchioles because of their big total area. So we may conclude that any disorder here affecting the terminal bronchioles may increase significantly the resistance in the respiratory system. The static properties of the lung include the compliance and the elastic recoil. Compliance is an intrinsic elastic property that relates a change in volume to a change in pressure. The compliance of both the chest wall, shown here, and the lungs contribute to the integrative curve of the compliance of the respiratory system. The elastic recoil, this is the tendency of a deformable body to return to its baseline shape. It will depend on two parameters, the tissue elasticity and the surface tension. This picture illustrates the compliance of the lung parenchyma. This picture illustrates the compliance changes in the lung parenchyma alone, in isolated lungs of cats. As we can see, when the lungs are filled with saline, there is no difference between the pressures during inflation and deflation of these lungs. However, in lungs in which airflow is present, there are different curves during inflation and deflation. As we can see, a lower inflation is observed, a lower volume is observed during inflation at the same pressure as compared with the deflation. The same pressure will generate a larger volume during deflation. So there is something acting to cause this difference. This is the surface tension of the alveoles. The next slide illustrates the importance of the surface tension. If two connected alveoli have the same surface tension, then the smaller the radius, the greater the pressure tending to collapse the sphere. Thus, to inflate successfully the alveoli, we need something counteracting the surface tension, thus allowing the inhalation of gas into the alveoles. This is the role of the surfactant factor present in the surface of alveolar membranes. The surfactant is a mixture produced by the type 2 alveolocytes. It contains predominantly phospholipids, mainly dipalmithylphosphatidylcholine, and also some other proteins. These hydrophobic molecules are covering the surface of the alveoli, thus displacing water molecules and reducing significantly the surface tension and allowing the alveoles to expand. The other factor playing a role defining the compliance is the presence of fibers, mainly elastic fibers, but also collagen fibers into the lung parenchyma. This slide illustrates the normal compliance observed and also changed compliance under different pathologic conditions. Loss of elastic fiber, destruction of elastic fiber, and the increased compliance in emphysema, or the increased elastic recoil and the decreased compliance in fibrology due to the deposition of more fibers into the lung parenchyma. Fibrology due to deposition of collagen fibers. This picture illustrates the work of breathing. The amount of energy needed to maintain the respiratory muscles during quiet breathing is small, approximately 2% of the basal oxygen consumption. However, it may change under pathologic conditions. There are two components of the work of breathing: the elastic forces, illustrated by this curve, and the resistance to the airflow. They are affected in an opposite way by the changes in the frequency of breathing. Let me note that a constant minute ventilation can be achieved through multiple combination of respiratory rate and the respiratory volume, the tidal volume. For example, the integrative, the total curve, combining the elastic forces and the airflow resistance, is presented here. The minimum energy expenditure is achieved at a breathing rate of 15 breaths per minute. This is the normal physiological breathing rate. For example, the increased elastic resistance, presented by the different curve of the elastic forces here, will be minimized by rapid shallow breathing, as shown here. Increased breathing rate will compensate the increased elastic force. This is here the total curve. And in contrast, if the airflow resistance increased, a displacement of the curve, the total curve, will also be observed. The resistive force impact is minimized by slow and large tidal volume breathing, by a decreased frequency of breathing, as shown here on this figure. Let's now discuss the matching of ventilation to perfusion. The matching of ventilation and perfusion is necessary to permit gas exchange by simple diffusion. A failure to match ventilation to perfusion, or the VQ mismatch, lies behind more abnormalities in CO2 and oxygen exchange in respiratory function. Normally, the typical resting minute ventilation is approximately 6 liters per minute. 1/3 of this amount fills the conductive airways, thus constituting a dead space or wasted ventilation. The alveolar ventilation is therefore approximately 4 liters per minute, while the pulmonary blood flow is about 5 liters per minute. So, this yields an overall ratio of ventilation to perfusion of 0.8. It is illustrated here. The respiratory system is presented schematically. The two lungs are oversimplified here. Uniform ventilation against uniform blood flow, this is the ideal. The saturation with oxygen, arterialization of the blood. Two different models of disordered ventilation to perfusion ratio exist. First one, uniform blood flow, however, no ventilation to 1/2. Here, in this case, an absolute shunt will be present. Because of lack of ventilation, the blood will not be oxygenated. An absolute shunt to the systemic circulation. Just the blood passing through the other lung will be ventilated. Or some disorder of the blood flow. Normal, uniform ventilation. However, there is no supply of a lung, in this case an alveol, on the skin. So this will generate another dead space in addition to the conductance space, which is dead in relation to the oxygen absorption. So alveolar dead space will be generated after a blockade of the perfusion of this area. Here the most common cases of ventilation to perfusion mismatch are presented. For example, the obstructive disorders decreasing the ventilation, non-uniform ventilation, to a section of the respiratory system. This is here presented. Or, for example, bronchitis, asthma are examples of the obstructive process interacting with the ventilation to perfusion ratio. Or here decreased or blocked supply of the blood as observed, for example, in embolism, exclusion of some alveoles from the gas exchange. This is the example, and with the generation of the dead space, alveolar dead space, and ventilation to perfusion mismatch. Let's now comment the disturbed control of breathing. This is the scheme illustrating, presenting schematically the respiratory control system. As we know, the lungs inflate and deflate passively in response to changes in the pleural pressure. Therefore, control over respiration lies in control of the muscles, respiratory muscles, chiefly the intercostal muscles and the diaphragm, but also the abdominal wall muscles. These muscles are under both automatic control and voluntary control. In addition, the frequency, the depth and timing of breathing are modified by information provided by the respiratory center from the chemical and mechanical receptors. Chemical and mechanical receptors. This slide presents records of the breathing. A normal breathing, amplitude and breathing rate is present here, and here bradypnea, a decreased respiratory rate. Usually the normal breathing rate varies between 10 and 24 breaths per minute. So below 10 breaths per minute, this is a bradypnea, or exceeding 24 breaths per minute, this is a tachypnea. Also, increased amplitude may be observed. This is known as hyperventilation. Usually it is due to metabolic acidosis. Breathing may be also changed in another way. Periodic changes, for example, the Cheyne-Stokes breathing here presented. This is here a stopping of breath. This is known as apnea. Apnea. After an apnea, it is observed a gradual increase followed by gradual decrease of the breathing amplitude to the new apnea period. How is it produced? During the apnea, the partial pressure of the CO2 will be increased. The apnea per se is produced by the decreased sensitivity of respiratory centers to the normal afferent signals, such as CO2 concentration and oxygen partial pressure. However, during the apnea, the partial pressure of gases will increase, so the increased partial pressure of CO2 will overcome the decreased sensitivity and to produce more and more breathing with higher amplitude. However, the increased breathing amplitude will eliminate the CO2, thus to decrease its partial pressure and to cause again a state of apnea. This is the periodic breathing of chain stocks. It is observed under conditions of decreased sensitivity of the brain neurons to the plasma partial pressures of gases. This slide illustrates the chain stocks periodical breathing disorder, but also the bio-breathing. Again, a periodical breathing type. However, there is no gradual increase or decrease of the amplitude of breathing. Apnea followed by another breathing period and another apnea. This is due usually to damage to the central neural system such as encephalitis. Encephalitis may cause this disorder of breathing affecting the respiratory centers. And one more type, the casping. As you can see, a fully irregular type of breathing. It is observed in agony before death, when the brain is out of function and lower centers are taking the control of the breathing. Casping breathing type. I will now discuss an important change, qualitative change of the respiratory function, the dyspnea. Dyspnea means bad breathing, abnormally uncomfortable awareness of breathing. This is here the mechanism of the dyspnea shown. As you can see, sensory cortex is participating, thus the information from the periphery, chemoreceptors, mechanoreceptors, metabolic receptors, is compared with the ventilatory muscular function. So, a mismatch between the ventilatory efforts and the information for the oxygenation will generate the sensation in the sensory cortex. Dyspnea intensity and quality will depend on the mismatch between the information and the motor cortex signaling, the control input, the discharge, and the chemoreceptors and other receptors information analyzed into the sensory cortex. Dyspnea may present as orthopnea. This is the dyspnea in the recumbent position. It is due to the loss of gravitational forces to contribute for the expiration. Let me remind, the expiration is a fully passive section of breathing. Another disorder, this is the trepopnea, unusual dyspnea only in a lateral decubitus position. It is observed under condition of heart disease, heart failure, or platypnea, dyspnea that occurs only in the upright position. It is due to deficient musculature of the abdomen. Let me remind, the abdominal musculature generates the intra-abdominal pressure necessary to move the diaphragm. So, loss of the diaphragmatic support will cause dyspnea, especially in upright position. This slide summarizes the mechanism of the dyspnea. Mostly it is usually respiratory dyspnea. Here, major conditions related to dyspnea are shown. Respiratory dyspnea. However, cardiovascular mechanism for dyspnea generation is also present, especially in congestive heart failure and pericarditis, among others. So, do not forget that dyspnea may be due to a cardiovascular mechanism. Let's now briefly comment the cough. The cough is an explosive expiration that provides a protective mechanism for clearing the airways for secretions or foreign material. The mechanism of the cough includes an afferent limb, receptors carrying information afferently through the trigeminal nerve, glossopharyngeal nerve, nervus laryngeus superior and nervus vagus, and also an efferent limb. The efferent stimuli are traveling through the nervus laryngeus recurrens and nervi spinalis. What the cough does represent? It includes a deep inspiration followed by a glottis closure. Later, a relaxation of the diaphragm follows and the muscle contraction against a closed glottis, thus creating a compressive effect, markedly positive intrathoracic pressure with narrowing of the trachea. Finally, the glottis will open, generating the cough together with the sound of the cough. Rapid flow rate producing an exhalation of the content of the passageways, so thus particles containing microbes will be exhaled by the coughing reflex, a robust expiratory change. The cough may be productive, eliminated, for example, mucus, or non-productive. Another change, this is the wheezing. Wheeze, this is to breathe with difficulty and noisily. Whistling, this is a musical or puffing sound made by air passing through the glottis or narrowed tracheobronchial airways in difficulty breathing. So this wheezing may be present during some process into the parenchyma of the lung, for example in pneumonia. This slide illustrates the main change into the respiratory system related to coughing or wheezing. For example, chronic pulmonary, emphysema, tuberculosis, carcinoma in the bronchi, and pulmonary infarction, pneumonia, and also bronchial asthma. These are the main changes generating these signs. Let's now consider the main mechanism, the general mechanism disturbing the respiratory function. First, the obstructive disorders. Obstructive disorders manifest by increased resistance to airflow as a result of caliber reduction of conducting airways. This increased resistance may be due to changes within the lumen, for example, in bronchitis or in the airway wall. This is the inflammatory response in bronchitis, or eventually within the supporting structures as observed in emphysema. This is the major changes contributing to the increased resistance to airflow, to the obstruction. The other mechanism is the restriction, characterized by the decreased volume capacity. In the same time, the passageways are intact. The decreased volume capacity may be due to widespread fibrosis, producing increased lung elastic recoil and decreased compliance, or infiltration or inflammation, thus scarring the lung parenchyma. It may be due also to change into the pleural space, such as pneumothorax, or to accumulation of fluid into the lung edema. The third type of general mechanism disturbing the respiration, this is the pulmonary blood flow deficit, especially observed in pulmonary thrombosis or pulmonary obstruction for an embolus, pulmonary embolism. And the fourth type, these are the disturbed mechanism, the disturbed control mechanism of respiration due to central impact, brain impact. Obstructive change into the respiratory system may be observed extrathoracally. As an example here, the obstruction by the uvula of the respiratory passageways during accumbing, for example during sleep, thus to generate obstructive sleep apnea. Especially the obstruction of the small passageways, such as terminal bronchioles, is important in generation the increased resistance because of the usually low resistance in this area due to the big total area of the terminal bronchioles. Bronchiolitis may be especially a condition modifying significantly the resistance of the passageways. Which is the functional characteristic of the obstructive change? Here, as shown by this portion of the slide, this is here the exchange volume in liters during respiration. This is here the normal tidal volume, inspiration and expiration. Forced expiration allows us to expire within 1 second, this is here the time presented, within 1 second about 80% of the vital capacity. This is the evidence for the normal conductance of the passageways. However, in obstructive disorders, as we can see, a significantly changed curve is present, thus allowing us to expire within 1 second. This is the forced expiratory volume, 1 second, about 40% of the vital capacity. This is the TIFNO parameter changing significantly as compared between the normal breathing and the obstructive state. This slide illustrates, let me to remind, we already discussed it, the change into the breathing rate under conditions of increased airflow resistance as observed in obstructive disorders. The breathing rate is decreasing. This is allowing to overgo the airflow resistance increased. The elastic forces are not increased too much. Let's now discuss the pathogenesis of the main obstructive lung disease, asthma. Asthma presents with airway inflammation and airflow obstruction, thus causing wheezing, chest tightness, dyspnea, cough and bronchial hyperresponsiveness. This is the fundamental abnormality. The initiation of asthma results from an exposure to defined allergens. Here, allergens sometimes potentiated by some other sensitizers, pollutants, and even concomitant infection with viruses. The inflammation will cause a chronic bronchitis together with airway hyperresponsiveness. As already noted, cough, wheeze, tightness, and dyspnea. This is triggered by allergen presentation, but also exercising cold air, some gases and particles into the inhaled air. All they may trigger the asthma attack, but it is caused by an allergic reaction we already discussed earlier. Allergens may be some complex organic molecules such as animal danders, dust mites, wood dust, but most commonly pollens. This is an antigen which, after being presented to T cells, will cause the sensitization of our immune system, and our mast cells will be covered by antibodies produced by the activated B cell and plasma cell. So at first presentation, the pollen will cause the appearance of a sensitized mast cell. The second presentation will allow the antigen to bind to the antibodies on the surface of the mast cell. As we already know, the binding and the formation of the immune complex on the surface of the mast cell membrane will activate the mast cell and cause the release by degranulation of mediators, and also a little bit later production of newly synthesized mediators such as prostaglandins, leukotrienes and platelet activating factor, and they also will be released. Thus, an early response will be observed due to the release of the preformed mediators, for example 15 to 30 minutes after the presentation of the allergen, and a late or delayed response 4 to 8 hours after the exposure. Thus, every subsequent presentation of the allergen will cause activation of mast cells, and especially activation of the eosinophils. Eosinophils will be recruited because of the release of cytokines from the activated mast cells. The degranulation will supply histamine among other mediators, and later the cytokines released by the cells, inflammatory cells recruited, and the prostaglandins and leukotrienes will cause a systemic or local, initially, inflammatory response. Let me remind, the inflammation is accompanied by increased vascular permeability and edema generated first locally into the wall of the passageway. This is here the normal respiratory passageway. Under condition of an asthma attack, edema of the bronchial wall is observed, thus causing a narrowing of the lumen. In addition, stimulation of the mucus production with formation of mucus accumulation plugs and additionally narrowing the lumen of the passageway. With the progression of the disorders, additionally, hypertrophy of the mucus glands will also be observed, thus increasing the thickness, additionally increase the thickness of the wall and reducing the lumen of the passageway. And finally, hyperplasia of the muscles into the bronchus also will be observed. The smooth muscles, they are hypertrophying, and the constriction, the bronchoconstriction due to the contraction of hypertrophied muscle fibers will also contribute to the decreased lumen. Now, let's compare the normal lumen with the decreased lumen in asthma. This will cause the obstruction, obstructive disorder. This slide summarizes with more details the cells participating in the asthma attack, mainly mast cells and eosinophils, but also other cells and also structural cells, especially epithelial cells and smooth muscle cells. Mediators involved are mainly histamine, leukotrienes, prostaglandins, and platelet activating factor, among others. And the effects, as already shown: bronchospasm due to the constriction of the smooth muscles, plasma exudation, edema of the wall, mucus secretion and obstruction of the lumen, and other structural changes. This is a preparation illustrating all the changes already reported. Here, the thickened airway muscle smooth muscles, the inflammatory cell infiltration in the submucous layer, the mucus plugs accumulation, and these are the characteristics of the narrowing of the respiratory passageways. Let's now comment the clinical manifestations of the asthma during an asthma attack. Cough is present due to the airway narrowing and the mucus secretion. Wheezing due to the caliber reduction of the passageways and generation of turbulent airflow. Dyspnea and chest tightness are also present, especially the greater muscular effort because of the spindle stretch receptors activation will contribute for the dyspnea, and hyperinflation may be present with thoracic distension. As a consequence of the obstruction, hypoxemia, decreased oxygen content of the blood, may be present because of the generation of areas of flow V to Q ratios or mismatch of the perfusion against the ventilation. Hypercapnia, increased partial pressure of CO2 and respiratory acidosis may also be generated. And the functional testing will show a decreased forced expiratory volume 1, decreased expiration within 1 second. And finally, bronchial hyperresponsiveness is present. It may be checked by a provocation testing for inhalation, for example, of methacholine. This is done in the clinical practice. The other important disorder, obstructive disorder, this is the COPD, chronic obstructive pulmonary disease. This is an imprecise term denoting the presence of chronic bronchitis or emphysema or both. So, let us first consider the chronic bronchitis. The chronic bronchitis is defined by a clinical history of productive cough during at least 3 months per year and in 2 consecutive years. It is usually combined with cigarette smoking, causing inflammation of the airways, mucosal thickening, and mucus hypersecretion. This is here a picture illustrating the normal respiratory mucus membrane and the change in chronic bronchitis. There is an increased number of glands into the submucosa, swelling and narrowing the lumen, and excessive mucus. So, look here, compare the epithelium. The one-cell layer, ciliated epithelium, is replaced by multicellular layer with no cilia. This is the metaplasia typically observed in chronic smokers. These changes in the bronchial wall will cause prolonged expiratory time and produce hyperinflation and alter the VQ ratio, followed by hypoxemia. The clinical manifestation of the chronic bronchitis, this is the productive cough. Often purulent sputum is present. Wheezing is present, forced expiratory volume 1 is decreased, and hypercapnia, causing respiratory acidosis. These are the characteristics of the chronic bronchitis. Let's now discuss the other component of the COPD, the emphysema. Emphysema presents with an enlargement of airspace distal to the terminal bronchioles, so this is a defect of the respiratory units. It is due to the loss of elastic tissue, thus losing the support to the airways during expiration and causing dyspnea. The main causes are smoking, cigarette smoke, together with some genetic factors, sometimes causing some deficiencies. especially deficiency of the alpha-no antiprotease inhibitor. A destruction of lung parenchyma is observed in emphysema. Let me note that parenchyma contains fibers, collagen fibers and elastic fiber, so the destruction of these fibers will cause the main sign of the emphysema, the increased compliance. How is this destruction activated? As already noted, the oxidants into the cigarette smoke will directly damage the elastin and collagen fibers, and also the elastases released by neutrophils and macrophages during the inflammatory response will also damage the elastin and collagen fibers. Another effect is the blocking by some components of the cigarette smoke of our lung defenses, for example, antioxidants. They are blocked, and also the anti-elastases, they are blocking the elastasis effect of the neutrophils. They also will be blocked because of the components of the cigarette smoke. Let me note, in 90 and more percent, 90 up to 95, the cause of the emphysema is related to cigarette smoking. As shown on this picture, the tobacco smoke, gender-inactivating antiproteases, also free radicals released, and neutrophil elastasis released. In some cases, the congenital deficiency of antiprotease will cause tissue damage with enlargement of the areas distal to the respiratory bronchioles. These are the structural changes in emphysema. Which is the mechanism by which the emphysema produces obstruction? This is here the normal air well held open by alveolar attachment, elastic support. As already mentioned, there is a destruction of the elastic fiber in COPD, in emphysema, so the elastic support is lost and the airway will collapse, especially which is the airway collapsing. Is this a bronchus? No. The bronchus is prevented by the presence of cartilage rings. However, the bronchioles are devoid of cartilage rings, so they are fully susceptible to collapse. In addition, inflammation will contribute to the mucus obstruction of the lumen. This slide illustrates the change of the compliance as compared with the normal value in emphysema during the loss of elastic fiber. The compliance will increase. This is the consequence of the destruction of the elastic fibers. In accordance to the clinical manifestations, two types of patients with COPD may be present. The first one, this is the pink puffer. This is a typical predomination of the emphysema in the clinical picture. As we can see, hyperinflation, thorax is changed, and also the discoloration is normal. Pink. Why pink? Because of the adaptive response, increased amplitude of breathing, puffing, and thus supplying enough oxygen to maintain an almost normal diffusion of oxygen. This is a puffer that is pink, while this is the blue blotter. This is a patient with COPD due to a predominating chronic bronchitis. Chronic bronchitis will cause decreased oxygen supply, and this is due to the narrowing of the air spaces conductive. And as we can see, there is also some edema present because of the generated left heart failure. This is the blue blotter. Cyanosis is present due to the low percent of oxygen, and this is the cyanotic appearance due to the presence of reduced hemoglobin. The reduced hemoglobin is blue. The bluish appearance is due to the cyanosis. Finally, few words about a severe disorder known as cystic fibrosis or mucoviscidosis. This is the major cause of severe chronic respiratory disease in children. Without treatment, about 90% of patients will die before age of 5 years. It is due to a genetic disorder. This disorder is illustrated here. The chromosome 7 is defective, thus causing a deficiency of the CFTR. The cystic fibrosis transmembrane regulator. This is a defect of a transmembrane ionic channel. In the airway epithelium, normally, it is shown here, the normal function of the chloride channel and the sodium channel. Now, the chloride channel being affected by the genetic disorder, sodium will be also retained to balance sodium, this is a cation, to balance the anion accumulation. So, as a consequence, the osmotic pressure will be increased in the cell and the mucus overlaying will be dehydrated because the osmotically driven influx of water. Thus, this disorder will generate an accumulation of viscous mucus into the airways, mucoviscidosis or cystic fibrosis. Which are the consequences? Of course, severe obstruction with complications. Initially, chronic bronchiolitis and bronchitis will be observed, and after months of year, structural changes in the bronchial walls, known as bronchiectasis, a permanent dilatation caused by destruction of the muscle and elastic supporting tissue. Under these conditions, infections will occur soon after birth, most commonly due to Pseudomonas aeruginosa, but also Staphylococcus and Haemophilus influenzae. As a consequence of the severe infections, respiratory failure will be generated and death will occur soon. Let me note that the abnormality in the CFTR, the cystic fibrosis transmembrane regulator, is not affecting only the airways epithelium. It affects also the gastrointestinal tract, especially pancreas, pancreatic insufficiency, the reproductive tract, male infertility, and also the liver and even the skin. This is here the classical cystic fibrosis clinical phenotype: bronchiectasis, severe obstruction, together with pancreatic insufficiency, infertility, and liver cirrhosis. This is the full-blown picture of the severe cystic fibrosis. Anyway, we can expect additional accompanying changes in other organs.